Good morning. Thank you, Needu. I'll be talking about challenges in the clinical diagnosis of uveitis. The management of uveitis is often challenging. Why? Because all these posterior uveitis entities looks very much similar, but they all have different etiologic diagnosis. Similar etiologic diagnosis can have different presentation, different clinical presentations also. And moreover, after all evaluation, 1/3 of patients, we won't be able to find out any clear etiologic diagnosis also. So what to do? The right protocol can prevent permanent vision loss. I'll show you some examples. This is a case of granulomatous anterior uveitis with mutton fat KPs and Busaka nodules on iris. So rule out TB and sarcoidosis in this type of uveitis. See another granulomatous looking lesion, but we can clearly see a mature cataract behind. So it's not a uveitis per se, it's a lens-induced AC reaction with lens deposits. Yet another patient, granulomatous looking lesion, but see carefully, there is no much KPs and AC reaction. All these are deposits on iris. So it was a case of iris metastasis from lung small cell carcinoma. These three are mild non-granulomatous anterior uveitis. But in the first case, it was first presentation in a young doctor. On clinical, detailed history taking, he gave history of treatment for tubulointerstitial nephritis 1 year before. So that was a recurrence. He had high beta-2 microglobulin. In the second patient, looking carefully, can see stellate KPs, secondary cataract, and absence of posterior synechiae. So that was a case of Fuchs. In the third patient, she had undergone surgery for CA breast and taken 1 dose of injection zoledronic acid 1 day prior. So that was a case of drug-induced anterior uveitis. Now these three hypopyon anterior uveitis cases. Look at the first case. This patient gave history of recurrent episodes on both eyes with neck stiffness and morning stiffness. So it's a clear-cut case of HLA-B27 associated anterior uveitis. In the second patient, again having hypopyon, shifting hypopyon with vitritis, and on evaluation had mouth ulcers. So it's a case of Behçet. Third patient, again hypopyon uveitis, acute onset with a history of septicemia. So it was an endogenous endophthalmitis. Now coming to intermediate uveitis, this young engineering student, healthy male, presented with intermediate uveitis like picture. All initial evaluation were within normal limits, but on careful examination could see some exudates floating in the periphery. Again asking questions, he gave history of IV drug abuse. So that was a case of endogenous endophthalmitis again. This patient again was treated as intermediate uveitis before with systemic steroids and no improvement. See on detailed fundus examination shows a peripheral toxo lesion. So examination of the eye as a whole is also very important. See, these are whitish lesions in the posterior pole. But in the first picture, it's a deep lesion. The margins are not well defined. Vessels are clearly seen. No much vitritis associated. So it's a choroiditis. Always rule out TB sarcoid in these patients. And second picture, it's more superficial, associated with vitritis. Vessels are not very clearly seen over it. Margins little more well defined. So it's a case of toxo-retinochoroiditis. Look at these white dots in the posterior pole. First, in the first photo, it's not associated with vitritis, deeper lesions. These are all choroidal granulomas associated with sarcoidosis. In the second picture, more whitish dots, again deep choroidal, associated with disc edema. it's a suggestive of white dot syndrome. In the third picture, the white dots are more superficial retinitis lesions associated with the disc edema and vasculitis here and there. So on careful examination, you can see the dots arranged very clearly in a pattern. So that was a case of DUSN. Now look at these photos. All looks very much similar with cotton wool patches and hemorrhages. But in the first two, bilateral vasculitis, patient had CME with occlusive vessels, and patient had this malar rash. So diagnosis is easy. It's SLE associated occlusive vasculitis. In the second set, patient was again young with a high BP, so that was hypertensive retinopathy. See these two vasculitis, any difference between these two sets? In the first picture, more of veins associated, periphlebitis in a young healthy male. So that was Eales disease. In the second set, associated with vitritis, vasculitis involving both arteries and veins, associated with disc edema and some retinitis patches here and there. So that was Basage. See this photo, it's not retinitis, it's not choroiditis also, some deep retinal lesions. While asking detailed history, he gave history of multiple sexual partners, and he also had genital lesions before, so that was a case of syphilis. Again, one pan-uveitis, one eye involved with pan-uveitis. Look at the other eye, shows history of old history, trauma patient. So it's a case of sympathetic ophthalmia. Look at these two images. Both looks very much like posterior scleritis, but no much inflammation. In the first photo, more of quiet fluid, and can see one mass underneath. This was a metastasis from CA breast. And the second patient was not having much of fluid detachment. It's a mass pushing from behind. So that was a case of CA lung, adenocarcinoma lung with choroidal metastasis. These two photos looks like toxo reactivation, but in the first picture, no vitritis at all, hemorrhages associated with that reactivation looking lesion. So that was secondary CNVM associated with toxo scar. In the second picture, associated with inflammation, vitritis, vasculitis. So that was toxo reactivation. So what is the key for a proper clinical diagnosis? Detailed history, meticulous head to foot examination, and a thorough ocular examination including indirect ophthalmoscopy. And keep in mind the eyes will see, only the mind knows, so keep updated. So with good clinical diagnosis, we can reduce the investigations needed, reduce the imaging tests needed, and we'll get the proper diagnosis earlier, can start the treatment earlier, so that can avoid a vision loss. Thank you.
Thank you, Dr. Risha. That was a wonderful talk and wonderful collection of the cases and the photographs. I think we can take up the questions at the end of the session. On to the next speaker, Dr. Partho Pradim Datta Majumdar, Senior Consultant in Uvea and Cataract Services, Shankar Netralaya, Chennai. So I'll be speaking on challenges in laboratory diagnosis of uveitis.
Good morning all. Thanks Neetu for having me here. So I'll be talking on challenges in laboratory diagnosis of uveitis, and thanks to Risha who has made my job much easier. So I'll be just showing what all cases Risha has discussed, just how to crack them in laboratory investigation. For example, a patient of anterior uveitis has come to your clinic. So what all test you will do? So there is a tendency that you will try to advise Montu test, anti-nuclear antibody, HLA-B27, torch titers, and serum AC. So we'll see how these tests are done and when not to be done. Now I'll show you two photographs. You just tell me. This test, you can see here that it gives you a appearance of the non-granulomatous anterior uveitis, and Montu test is 15. So will you start ATT? And this is a case which has, you can see that granulomatous exudates, the lump of cellular aggregates in the anterior chamber, often giving a look of mass-like lesion, and it's positive for HLA-B27. So what we'll do? Now, similarly, so we have to understand that no, we don't treat the laboratory test, we treat the disease. So positive HLA-B27 MONTU test, highly positive MONTU test in absence of a proper clinical phenotype does not matter. Now, one more example I'll give. You can see here the cellular anterior cells, and the patient has come here, a 45-year gentleman, recurrent anterior uveitis, fundus is within normal limit, and anti-toxoplasma IgG is highly raised. Now, will you start anti-toxoplasma treatment? Now, another patient, a 28-year-old lady, retinochoroiditis, you can see that at the edge of the scar with a severe vitritis, and the anti-toxoplasma IgM negative. So, won't you use toxoplasma treatment? So, this is how your clinical decision will change when you see a proper clinical phenotype. So you have to understand that we are lucky enough and we have a test which is most important in uveitis. This is that we call it microscopy. Now, this is not this microscopy I'm talking about. I'm talking about the microscope which gives you a ability to see in 20 to 40x magnification, and we are the only people in this medicine world who can see an inflammatory cells, who can see and quantify the inflammation. We can see whether a blood vessels is inflamed or not. Go to any other subspecialty of medicine. For example, take the rheumatologists. Even if you see or suspect giant cell arteritis, they need to send the patient to a surgeon who will do a biopsy and then do a histopathology, and then they will understand that yes, that vessel is inflamed. But us, we can just see and we can tell that this vessel is inflamed. It will require anti-inflammatory treatment. So we need to use this utility very judiciously. So clinical pattern recognition is the key. I'm not going into the details, but you all know how to differentiate between a granulomatous and non-granulomatous, and it is the most important test in your uveitis clinic while you start uh, examining a patient. So try to differentiate between these two and then start your investigation. Now, when we talk about granulomatous investigations, we have so many tests. We have MON2, HRCT and all. So one by one we'll see here, but you can see here that serum angiotensin converting enzyme and serum lysozyme. This is a very important test in sarcoidosis. But sometimes you may have to depend on the HRCT test because these tests are often very less because it represents the granuloma load of the sarcoid, and sometimes in ocular sarcoidosis there can be localized granuloma. So liver function test is important because it is raised in sarcoidosis, ATT and immunosuppressive, so you have to do that properly. Now, MON2 test again is a very important test. If it is positive, you know how to interpret and what all of you have given. But if it is negative, then also it helps because the tubercular energy is very important in sarcoidosis. So it gives you an idea that even the tuberculin test is negative, it can be due to sarcoidosis. Remember a few things. Don't treat the patient based on MON2 test alone. Don't repeat the MON2 test. And MON2 test may boost the quantiferon gamma response if the interval between the two exceeds 3 days. So keep that in mind while ordering both the tests. HRCT test is highly sensitive. It is more accurate than the chest X-ray. So always try to delineate that. Coming to the systemic rheumatic disease, if you see, there are so many parameters, but you have to remember 3 important points. One, no single test is diagnostic and most of them are non-specific. Like RA is positive does not mean that the patient has arthritis, or ANA is positive does not mean that the patient can have autoimmune disease. Whenever in doubt, do refer to the rheumatologist to look for systemic evidence or not. And sometimes if you have to remember, a biomarker which is negative now can be positive in later part of the disease. A patient has come with fibrinous anterior uveitis, you have done a HLA-B27 and it is negative, but if you are doing the test maybe after 3 to 4 years, it can become positive also. Those things you have to keep in mind. Now, coming to the few investigation, I must tell you that don't advise this torch titer because this herpes viruses are ubiquitous and not required that you need to see the serum because it can be positive in any patients. Now, just my favorite rule, I always tell that fisherman guides for the laboratory investigation. First, investigation in uveitis is not fishing expedition. You see a case of uveitis and does not mean that you will try to investigate all the investigations you have, because sometimes we'll see that how it can cloud your mental diagnosis. Now, sometimes you have to understand a little bait catches a large fish. Like how it happens, like for example, a patient has come with hypopion or sudden some relapse, and if you are careful enough, that patient is cachectic, very pallor, so peripheral blood smear can actually pick up leukemia. I keep showing one case where the lady presented with VKH like symptom, and then the syndrome, and then it was a case of leukemia picked up only by peripheral blood smear. So peripheral blood smear can be a very useful investigation in certain conditions. The last thing, and which actually relates to the first dictum, is that don't fish for the things you don't know how to cook. For example, a patient of anterior uveitis has come and you have done a ANCA. There is no systemic evidence, but you have it tested for ANCA and ANCA is positive. Now, without any systemic evidence, the patient is having ANCA positive disease is very rare. But you are in a now dilemma because the ANCA is positive, so you don't know how to handle it. So better don't do investigate anyone. So I'll give you again Cochrane's aphorism that before ordering a test, decide what you will do if it is positive or negative. If both the answers are same, then don't do that test. So in certain condition, you have to be very careful that. So I'll just conclude with my how to we take from clinic to laboratory. Determine the predominant site of inflammation, which Risha pointed out so nicely with color atlas like photographs. Try to decode the clinical phenotypes, do a slit lamp examination, take a meticulous history, and also look for the systemic sign. So I'll just follow the Risha's path and I'll just give you 3 examples of how to approach a case of hypopion. For example, we can divide it into scenario A, scenario B, scenario C. So if you see the scenario A patient, we assume that a patient of hypopion has severe fibrinous reaction, non-granulomatous anterior uveitis. The patient also gives us a history of lower backache and she complains of recurrent attack of attack. So what can be the possibility? Probably we are dealing with HLA-B27 from the history and the clinical phenotype, and we'll order HLA-B27 and only X-ray sacroiliac joints. These are the two. Now assume the second condition, the second patient has a panuveitis, the mobile hypopion, and also gives history of recurrent oral and genital ulcer. Then in that patient, no need to order HLA-B27. Here we'll directly order HLA-B51 and send the patient to a rheumatologist because we are suspecting Behçet disease. Now let's assume the third one, the patients, the granulomatous panuveitis, there is a history of hospitalization in few days back. Our patient is a known case patient of diabetes mellitus and also gives you a history of a septic foci elsewhere in the body. So in such scenario, as Risha nicely seen you a case of endogenous endophthalmitis, the probable diagnosis endogenous endophthalmitis. So what we will do, we'll just do a vitreous biopsy and send the patient for blood and urine culture. Thank you.
Thank you, sir, for such a great talk. I think with this, we have, it's clear that we have to treat the patient and not the labs. And I would like to invite the next speaker, Dr. Lekha T, Senior Consultant, Uvea and Medical Retina, Giridhar Eye Hospital. Ma'am will be speaking on challenges in imaging in uveitis.
Good morning, everyone, and thank you, Dr. Neetu. So after that two excellent talks, this is just my effort to know the importance of imaging in uveitis. So as we all know, imaging has become a core component in the evaluation, management, and monitoring of uveitic conditions. And these different modalities of imaging give us a lot of complementary information and serve as building blocks in the diagnosis and follow-up. However, sometimes imaging can be challenging when you're not sure as to when to do the imaging and which imaging modality that we have to choose, how to interpret the findings, and also correlate with its clinical features. We'll go through some case examples. So this is a 37-year-old healthy male on treatment for recurrent anterior uveitis with cystoid macular edema in the left eye for many months. His workup was negative. When he came to us also, he had non-granulomatous anterior uveitis and significant cystoid macular edema. So because of the multiple recurrences, we thought we'll just do an imaging, and digital fluorescein angiography revealed not only the hot disk and perifoveal leaks, but also diffuse capillaritis in all the quadrants, and subsequent workup showed showed that he's HLA-B51 positive, and he could be stabilized with appropriate immunosuppressive therapy, and he remained stable over time. So the challenge was in the decision making, because many times when the findings are predominantly in the anterior segment, we may not actually proceed with the detailed imaging, but DFA has a role in any case of very severe, atypical or recurrent anterior uveitis, or those cases with CME, because information that we get from the imaging enable more accurate characterization of uveitis, and ultra-wide field DFA is especially useful in picking up vascular leakage, not only in active uveitis but also in inactive uveitis and in eyes with CME. So this is a 9-year-old boy who's been having severe non-granulomatous anterior uveitis, 3+ cells, not responding to topical medications. Fundus and OCT was normal, workup negative, and with the difficulty we could convince the parents, and in his case also DFA showed extensive capillaritis with fern-like leakage, and finally he required biologicals for stabilization. So in pediatric uveitis also, the fundus imagings can be very subtle, and activity on DFA is an indication for systemic therapy. This is a 61-year-old lady who was referred to us by the rheumatologist, and she had only mild anterior uveitis with occasional cells. Fundus was also grossly normal, but she had blood reports which showed that AC was raised and Manto was negative. So we decided to go ahead with dual DFA and ICGA. DFA showed hot disk and perifoveal leaks, whereas ICGA showed multiple hypodense lesions suggestive of occult choroidal granulomas, and further workup led us to a diagnosis of sarcoidosis, and she could be stabilized with immunosuppressive therapy. So whenever a choroidal pathology is suspected, a DFA alone is not enough. It has to be combined with ICG angiography also. This is a young male doing his engineering. He's been having poor vision for 10 years, undergone multiple treatment. All his uveitic workup was negative. When he came to us, he had chronic anterior uveitis with posterior synechiae and small pupil. Fundus examination was not possible, no view. So normally in such cases, we do a B scan. B scan showed an unexpected disc drusen in both eyes and mild RCS thickening. But don't stop there. We tried our optos, which gave us an information that there is no major pathology in the fundus, except for the disc elevation, and though a hazy image OCT macula showed that there was a foveal contour was normal, but then we proceeded with DFA, which showed hot disk and diffuse capillaritis, which enabled us to start a systemic therapy, and he has been remaining stable. So even in small pupil, if you have the facility for confocal imaging, it will give you a lot of information, because here the reflected light is very narrow. It is captured through a small confocal aperture, and all the other scattered light is suppressed, which gives you a very clear image in small pupil. And this is the same principle that is utilized in optos wide field imaging, which can give you almost 200-degree view of the retina through a small pupil. So don't ever give up in patients with small pupil and chronic uveitis. This is a young male who noticed defective vision since 1 week. He consulted a local doctor who was prescribed glasses with myopia correction, but he was not happy with that. When he came to us, he had very shallow anterior chamber, slightly raised IOP, closed angles, and ciliocoroidal effusion on uveum. So normally, what do you think? Though he had a past history of migraine, he was not on any treatment recently. So our first possibility of drug-induced angle closure could not be convinced, because there was no positive drug history. The other possibility was a VKH, but his fundus and OCT was normal. However, his multicolor imaging showed significant ILM folds over the macula, so we decided to wait, and 1 week later when he came, the fluid had already started, and OCT helped us to confirm the diagnosis of VKH. So here the problem was the patient presented in the very early course of the disease. So the same confusion can happen when it is too late also, when already more structural alterations would have happened, either due to scarring or pigmentation. This is a 44-year-old male who's been having defective vision for 2 years, undergone multiple treatment, TB ruled out. Vision was quite affected with 660 in one eye and counting fingers in the other eye. He had non-granulomatous anterior uveitis and also vitritis, and for other fundus changes could not be made out very well because of the hazy view. So intermediate uveitis was considered, and we proceeded with the workup. DFA again was little difficult to interpret because the images were not clear. Some kind of mixed hyper pattern was there, and little bit of diffuse capillaritis. OCT showed intraretinal fluid, hyperreflective lesions in the outer retina, and significant EZ loss. So what are we looking at? I was finding a little difficult to come to one diagnosis. Anyway, all his workup turned out to be negative, so we gave a trial of oral steroids, and when he came 1 month later, later, the fundus view was better, which revealed little more pigmentary changes, but it was delineated much better on autofluorescence, which gave us a diagnosis of pigmented paravenous retinochoroidal atrophy. And further workup, including ERG, showed the reduced photopic and scotopic response. So here the challenge was because of multiple pathologies, and we were unaware of the pre-existent undetected retinal pathology, and the coexisting inflammation was interfering with the visualization. So please remember, uveitis can contribute to the pathogenesis, and it can be the initial manifestation of these kind of retinal dystrophies. So in any patient with indolent uveitis, RP or its variant should be suspected and ruled out by MMI. This is my last case, 61-year-old male who has been having defective vision for the last few months, already undergone anti-VEGF injections and PRP in one eye, and he was also treated for inflammation elsewhere with periocular and systemic steroids. Systemic history revealed diabetes, hypertension, CKD, and HIV, and he was on ART. His recent CD4 count was good, and viral load was not significant. On examination, vision was counting fingers in the right eye, 6/9 in the left eye, anterior segment was quiet. Fundus showed PRP scars in the right eye and hard X-rays near the fovea, and left eye had moderate NPDR. Autofluorescence showed some patchy hyperfluorescence around the fovea only in the right eye. However, OCT showed significant intraretinal fluid, subretinal fluid, hyperreflective irregular RP, pachychoroid, and also in the left eye something like a choroidal granuloma. Again, it was a very confusing picture. Other OCT scans showed significant RP undulations and SRF in both eyes. RNFL edema was also there in both eyes. So what are the possibilities? Definitely he has diabetic retinopathy, but along with that, is it VKH or some posterior uveitis with a choroidal granuloma? Is it HIV related, or is it a chronic CSR or some kind of masquerade? Yeah, so we proceeded with further workup. In the meantime, we thought let him continue the steroids. At 1 week, we thought maybe he's improving, but by 3 weeks, he was definitely worsening with increase in the retinal fluid. All his blood workup turned out to be negative. We did his DFA, which was again difficult to interpret. Diabetic retinopathy changes were there. Along with that, there were diffuse window defects, then the blocked fluorescence due to the laser scar. So it was all creating a lot of confusion. But a little more careful evaluation showed focal RP leak in the right eye as well as in the left eye, revealing a diagnosis of CSR. So here the problem was because of multiple ocular and systemic pathologies, and also it was a lasered eye which was all creating difficulty in the interpretation. And remember, CSR is an important differential diagnosis of VKH, and we should always need MMI for confirmation. So whenever the findings are atypical, remember to rule out masquerades. Thank you.
Thank you, ma'am. Thank you for this very informative talk. And it was a beautiful collection of cases and photographs. Yeah, we'll take the question at the end. Now I would like to invite Sir Uli Pato sir for the next talk on challenges in uveitis, overlappers and combined troublers.
I think I'm lucky enough because you have again showed some cases which I'll be briefly discussing. So this topic is very fascinating. I don't know how they decided. It's like such a, I'm going to conferences for so many years, but nobody has asked me to talk on overlappers. So this is, I think, the most important part in our medicine or in our clinical practice also. So if you see the mistake we do in our clinic, no. So what happens under right circumstances, certain condition will closely mimic one or another, and leading to a serious consequences, and you will realize that, oh, I should have thought about it. So I'll just go into little that psychological part of it, that why it happens. So if you see that there will be always a pattern recognition and anchoring bias, we call. So relying on the familiar patterns lead to the premature conclusion. For example, we see a patient of red eye and immediately we jump that, oh, it will be conjunctivitis. Then there is something called heuristic, like recently seen and commonly diagnosis. If you have seen some case in conference, or you have read about some entity, and in clinic you try to overdiagnose that. So there is a tendency for that also. And then there will be a confirmation bias, like tendency to focus on the evidence supporting the initial your assumption rather than the conflicting ideas. So that's what I call that falling in love with your diagnosis. You don't try to understand that there are certain features which are not matching with your diagnosis, but you try to focus on what are the features which is matching with your diagnosis. diagnosis. So that is called confirmation bias. And then there will be a cognitive load. When you are in a busy OPD, you are stressed, you are highly tired. So that time these things will overpower it and you will be like you are prone to do mistakes. And then the familiarity trap, that overconfidence in well-known conditions, because you have treated so many of these conditions, no, that sometimes you will do that while doing cataract surgery, you have done a PC rupture. And if you go think over a little that you are so familiar to it, you don't try to understand that, oh, I have to go slow here. And that's how we create mistakes. So the familiarity trap is the most important bias in such cases. Now you see this case already, Lekha madam has nicely shown you a case. It is much more simpler case, but this patient was diagnosed with VKH. And the patient was treated with IVMP and oral steroid. And finally, when the patient came, and you see it is bilateral. So when we did a fundus fluorescent angiography, you can see the leaks which are increasing in size and intensity in both eyes. So it was a very rare case of bilateral CSR. So these are the cases invariably you will miss in your OPD if you are not doing multimodal imaging, as she pointed out. This is another patient, a 43 years old male who presented with diminution of vision, gave history of oral ulcer, and there was a panuveitis, so diagnosed as Behçet disease. You know that oral ulcer is very common. Behçet ulcer disease, if you see, it is severely painful, but the common oral ulcer anyone can have. So these patients were diagnosed as a Behçet disease, started on immunosuppressive azathioprine and the corticosteroid high dose. From in elsewhere, and patient developed severe eye pain, developed RD, that eye became pre-thysical, and came to us when he started developing the involvement of the other eye. So that's where we realized that it was a case of acute retinal necrosis. So sometimes this kind of severe vitreitis and where you can't see the peripheral retinal retinitis properly, and the patient gives you a history of that, okay, I have oral ulcer, frequent oral ulcer, so you tend to miss this mistake. There is a very important article in Vigio, you can go and read about it. So the second most mistake we do in Behçet's and acute retinal necrosis if we are not careful. Now the third and the most important overlapper is the panuveitis and endogenous endop, because it is, you have to be very careful ruling out that. History taking is very important in ruling out such cases of panuveitis versus endogenous endophthalmitis. So the main is any cases of panuveitis, you have to be very careful before starting aggressive medical treatment. Now tips to overcome the overlappers, the stop treating the clinical signs. For example, in first case, why we did the mistake, we try to treat the exudative RD without knowing the root cause of the exudative RD or the SRF in the fundus. The subretinal fluid in the fundus was because of the CSR, not because of the VKH, but we did not try to delineate that cause and tried to just treat that SRF, and that's why we did mistake. So clinical signs should not be treated, go to the root cause, why that clinical sign is occurring. Don't fall in love with your diagnosis, always question yourself, am I right? Am I doing any mistake? Some cases require special attention in time. If you are too busy, advise some imaging, call the patient in a day where you are relatively free, revisit your diagnosis. So that is important. And remember, patient may lie. That happens, so don't believe patients entirely. And something you have to understand, just because a patient does not have a history of a particular condition does not mean that it can happen. Every disease has a first occurrence. For example, we take a history of COX, contact with the COX. No, it's not there. That does not mean that the patient cannot have a COX. History of high risk behavior. In many patients in a sophisticated OPD, they will be reluctant to tell you about their behavior and all. So you should not take those things. You have to order. For example, TPHA, you have to order in all patients with any cases of uveitis, because syphilis is a great masquerader. So don't go by patient's profile that he is looks like he is a posh, he is very aristocrat, he denies any kind of high risk behavior. So we should not advise that. So don't fall prey into those, and cast a wide net of possibilities and avoid zebras, but keep them in mind. Now the zebras, if you know, it's an American medical slang for arriving a surprising and exotic diagnosis. So it is said that the professor Jonathan used to tell that when when you hear hoofbeats, think about horses, not the zebras. But in uveitis is such an entity. Here, when you hear the hoofbeat, you have to always remember that it can be zebra also coming to your OPD. So that is very important. For example, I'll show you this case. A young lady with a history of diminution of vision for 1 month, history of headache and fever she gave. Remember, this history of headache and fever was there. Fever was recurrent, and there was a history of headache. And this was the optical coherence tomography photograph. You can say multilobular septi with subretinal fluid. And this was the picture fundus photograph, which is showing pinhead leak. And you can see that there is a placard pulling of the dye. So immediately I jumped into the conclusion that, oh, it can be a VKH only. So only thing helped me is that I just looked at her, and she was very cachectic and looked very pale, and which bothered me is that why there is a recurrent history of fever. So fever should not come so often in VKH patients. So what we did, we just did a peripheral blood smear, as I was showing, and it showed 95% blood cells. So she was referred to the hematologist, and diagnosis of acute myeloid leukemia was made, and patient was started on chemotherapy. And if you see here, this is the condition. Here it looks like a VKH, but this FFA picture is often deceiving. You see the list of entities, and you note here that so many muscularate syndromes, the leukemia, lymphoma of the uveal tract, metastatic carcinoma, all they can have pinhead leak and placard pulling. So sometimes if you are very sure that it is, oh, they are VKH, just think about it, that are you missing something? Now, coming to the combined trouble, I'll only show one case because it will be beyond the time limit for this discussion. This is one of the best combined trouble case I have managed. A 35-year-old male presented with history of blurred vision, and the patient was treated with intravitreal bevacizumab, oral steroid. There was a quite AC, few cells in the anterior vitreous. I took the detailed medical history, and the history revealed that there is a two-year history of primary infertility. The semen analysis of him revealed azoospermia. And the patient also gave me history that in his earlier childhood, there is a history of exposure to TB when his uncle was suffering from tuberculosis of the bone. Now, with this picture, we just investigated the patient. Montu test was highly positive, quantiferin was negative, and as you can see, the serum AC is raised and serum lysozyme is within normal limit. Now, we did HRCT, and a radiologist called me that we need a bronchoscopy to confirm that, which patient refused. You can see here, mainly the patient's HRCT was showing mediastinal and hilar lymphadenopathy. I'll just take 1 minute and wrap up. So ultrasound Doppler showed again some epididymy orchitis. Again, the urologist told you have to go for a testicular biopsy. The patient refused both the biopsy. So we are in a point where we have a tuberculosis in favor. We have positive Montu, history of contact, endemic area. Genitoury involvement is more common in TB. Whereas sarcoidosis, the HRCT is favoring a diagnosis of sarcoidosis, raised serum AC, and ONH granuloma was more common. So what we did, we took the middle path. We started the patient on ATT and also started the patient on high dose of steroid. And at 3 months, you can see the vision improved significantly. 6 months, his he was oligospermic on repeat semen analysis, and he informed us about his wife's conception. And after 4 years, this patient every year come to my OPD from Calcutta to see and give a sweet because, and after 4 years, when I saw him recently, his second year kid is 6 months. This is another, just I want to show another patient of retinal vasculitis I published with Ashad and Hashali. What is the lupus? There is the rheumatoid arthritis and the lupus combination of both. And this is a Neethu's publication where not a double trouble. It was a case of retinochoroiditis which presented with syphilis, tuberculosis and human HIV infection. So ground rule for tackling combined inflammation, believe that overlap of clinical condition can happen. Always keep a high index of suspicion. Syphilis and HIV, always investigate for both if one of them is positive, and take care of multidisciplinary approach if you want to tackle the combined troubles, and in case of doubt, always take a second opinion. Thank you.
Thank you, sir. Thank you, sir. Beautiful presentation, as always. And next I invite Dr. Neetu Latif, Senior Consultant from Giridhara Institute, for her talk on challenges in treatment of uveitis.
Thank you, Dr. Risha ma'am. So I'll be talking on challenges in treatment of uveitis case scenario. So case 1, it's a 43-year-old female with blurring of vision in the left eye more than the right. Since 3 weeks, status post cataract surgery in both eyes 14 years back, and the vision and refractions as follows. And as you can see in the right eye, the IOL is partly displaced into the anterior chamber along with the bag. And also both eyes, we could make out the fine stellate capes distributed all over the cornea, and these sort of nodules in the pupillary margin, and there were deposits on the IOL surface. Fundus, the media was hazy due to the wet haze, and there were floaters, and the OCT macula was within normal limits in both the eyes. So this is a case of bilateral Fuchs uveitis, probably could be an acute exacerbation of Fuchs uveitis. I started with a short course of topical steroid in this patient, and her BCVA improved in 1 month's time. So the message here is no one is allowed to die or go blind without a trial of steroids. Even though we know that steroid has a very limited role in Fuchs uveitis, in such a case scenario, I don't think it's a harm to try a course of topical steroids under careful monitoring of the intraocular pressures. So case 2, 54-year-old male patient with gradual loss of vision since 4 months. He's a non-case of alcoholic cirrhosis, diabetes mellitus, and history of skin rash 1 month ago on his left arm. Fundus examination, there was bilateral retinal vasculitis, and there was a retinitis patch inferior to the disc in the right eye, and also in the infratemporal arcade in the left eye. So we did a fundus fluorescent angiography. There was diffuse capillary leak with fern-like pattern and cystoid macular edema. OCT showing cystoid macular edema in both the eyes. So the diagnosis is not so challenging because it's actually B51 positive Behçet's disease. We took a dermatologist opinion and a rheumatologist opinion. So the dermatologist said that it is a herpes zoster infection which has happened 1 month ago. So here I was a little hesitant to start with a proper course of treatment because of his systemic condition. So we had a careful discussion with the rheumatologist, made sure that the patient was properly counseled, gave him the option of the treatment, and then started with the IVMP course, and explained clearly the probable chances of herpes zoster reactivation and his systemic condition. So, then careful monitoring was done each day after IVMP. And then, but on treatment, he developed variceal bleed and esophageal candidiasis, and we had to stop all the treatment. And once he was systemically stable, we took the gastroenterologist opinion and then restarted on a lower dose of steroid and immunosuppressive therapy. And at the end of 3 months, his vision is maintained to 6.6 N6, and systemically also he's doing well. So the message here is in any case of associated systemic disease, do go for a multidisciplinary approach rather than treating the patient on your own. So case 3, it's a 47-year-old female with sudden onset redness and pain. And as you can see, it is a bilateral exudative retinal detachment with RP undulations and possibacillary detachment. No doubt it's a case of VKH, treated with IVMP, oral steroids, and IMT. After 1 year of treatment with maximum dose of IMT and oral steroid, the patient had a vision drop in the left eye. As you can see in the fundus photo, it's a sunset glow fundus, and in the right eye, there's a subretinal fibrosis, and in the left eye, there is a peripapillary CNVM. So then we advised the patient to go for intravitreal injections. But then the patient was a poor patient, she couldn't afford, but still we convinced her, managed her to get the injections done. So, but in repeated Avastin injections, 6 injections were given, but still the CNVM was not under control. And the patient cannot afford any other intravitreal or biologics. So what to do this patient? So we then thought, why don't we give her intravitreal triamcinolone? Luckily, she was not a steroid responder. And we gave 2 mg with Avastin, and then the vision maintained to 636 and 36, stable even after 3 months of intravitreal injection. So the message here is the good physician treats the disease, the great physician treats the patient who has the disease, by Sir William Osler. So case 4, a 43-year-old doctor, non-case of sacroiliitis under rheumatologist care. She had recurrent episodes of non-granulomatous anterior uveitis in the left eye. treated with topicals. She has raised intraocular pressure noted after starting topicals. Repeated episodes of anterior uveitis in next 7 months. Query the cause. May not be due to the back pain because it is not alternating in both the eyes, sticking on only to the left eye. May not be a steroid responder. Could it be a hypertensive iridocyclitis? No features of viral uveitis in the eye. AC-TAP was done, PCR was positive for CMV, started on antiviral therapy and no recurrences so far. So the message here is revisit your diagnosis whenever you think that something is not going in the right way. Case 5, a 15-year-old girl with diminished vision in the right eye since a month, denies any systemic illness, and her FFA, the right eye, showed a diffuse capillary leak, fern-like pattern. Left eye was normal and a very large cystoid macular edema. And the autofluorescence also, you can make out the cystoid macular edema. So she was treated with IVMP, biologics, adalimumab, and maintained on a low dose of methotrexate. Vision maintained from counting fingers to 615. But her complaint was that she's still perceiving a ring-like defect. So then I repeated the fundus fluorescent angiography after 3 months. But significant improvement was noted in the angiography. But still, in the autofluorescence, you can see this ring-like defect. And also the OCT showing a ellipsoid layer discontinuity. So I probably don't know the cause behind it. I think it's probably because of the resolving CME, but I've not seen a resolving CME with a ring-like appearance in the autofluorescence. And case 6, a 43-year-old female with left eye sudden drop in vision on treatment for SLE. She was treated by the rheumatologist with biologics. Her blood CMV titers were high, and she had a CMV retinitis. So she received 4 doses of intravitreal ganciclovir elsewhere, also on systemic ganciclovir, patient responding well to treatment. On subsequent follow-up, I noticed RP mottling in the mid-periphery, which is picked up in the autofluorescence. Did a ERG, the ERG showing grossly reduced amplitude for scotopic and photopic responses. So I don't know what is the diagnosis, but still I suspect a retinal toxicity due to the intravitreal ganciclovir. So to conclude with, listen to your patient. He's telling you the diagnosis. Do always go for a multidisciplinary approach in cases of uveitis. Revisit your diagnosis whenever you think that something is not going in the right way. Always be vigilant and modify yourself depending on the clinical signs. Thank you.
Thank you, Neetu. The take-home message of this session is to become a good uvea specialist, you have to be a good ophthalmologist as well as a good physician. You have to talk to the patient, you have to examine the patient again and again, and discuss the treatment options and revise your treatment. Thank you, Neetu. And any questions?
I have a question to Pathu, sir. Sir, when it comes to Manto or Quantiferon, which one is the most reliable test? Which one will you consider in your...
I think both Manto and Quantiferon, it can detect the latent tuberculosis only. So for me, I think the important will be the clinical phenotype. If the clinical phenotype is not suggestive of TB, I won't advise any of them.
Okay. Any more questions?
Honestly speaking, I have spoken to our urologist also and the chest physician also. We are not sure actually what this was something like just taking a middle path because it can have both. But of late, we are now aware of that entities. We call it TB and sarcoid overlap. It is now, I think, already it means there are several publication on that in India it can happen. Both the overlap of the computer this can happen. And this why I was discussing this case, because now if you see there is another entity coming up which is called pediatric sarcoid or blau. Same kind of overlap and nobody knows. Earlier, means 5 years back, we are treating these children as a sarcoidosis. And now after that NOD mutation diagnosis, laboratory diagnosis we are realizing that we are actually treating BLOS. So there are some patients with me who now we have done the test and realized that that was a BLO we treated for 3 years as a pediatric uveitis. So this is how our knowledge is actually transforming.
So with this, I think we can wind up the session, and I would like to invite Dr. Balamani Madam to hand over the memento to Dr. Patho sir.